So you see the old ADA algorithm, that is, that it was tier 1 and tier 2. HbA1c more than 7, add sulfonylurea. If not, add pioxanatide or basal insulin. Or add insulin, intensify insulin. The third one is add pio, add sulfonylurea or the basal insulin. The fourth one is add exenatide. If not, go add on sulfonylurea, pio and insulin. This was way back, the old ADA algorithm. Over a period of time, how the thinking process has changed, how the innovation has occurred, how the research has occurred, and how the newer molecules, accordingly the algorithm went on changing. So you can see the new ADA algorithm. So this is what I'm sure all of you are aware of this particular thing, where on the onset of treatment, like type 2 diabetes naive patient, lifestyle modification, metformin, then assess the overall risk factors the patient has got, whether it may be ASCVD, CKD, hypoglycemia, weight loss issue, cost is an issue. Accordingly, the things have changed and the newer the molecules have been implicated in the management. So the multiple pathophysiological aspect is addressed from the beginning, where the sweetening 16 has been considered, been addressed from the beginning, and so that the long-term morbidity and mortality is reduced. So what are the possible newer therapies in type 2 diabetes based upon the understanding of the newer pathophysiological aspect? You can see here, it looks a busy slide, but concentrate on the right hand side, that is the possible future therapies. It may be prebiotic and probiotic food supplements, SGLT1 and SGLT2 inhibitors, satiety inducing agent, incretin mimetics, insulotropic agents, tissue selective and smart insulin, glucagon receptor antagonistic, direct inhibitors of hepatic glucose production and stimulates of muscle glucose uptake and metabolism, small molecule insulin mimetics, adipokine analogs, novel insulin delivery routes, that is oral, buccal, skin, enhanced insulin action. I am sure it is going to be the future. With the innovation of GLP-1RA in a tablet form, I am sure the oral insulin should come. And the novel SGLT2 inhibitors, the newer SGLT2 inhibitors are coming into the market after 3-4 which are there in the market. Still it is ongoing, newer molecules are coming. So if you see over a period of 25 years history of type 2 diabetes, from 3 reasons, 8 reasons, 12 reasons, 13 reasons, and now the 16 reasons are there. This is what this ominous octet and beyond. Why it is important? The more the research aspect is there, then it gives forward to the innovation of possible future therapies in the management of type 2 diabetes. So this paradigm shift based upon the pathophysiological represents a novel approach to the treatment of type 2 diabetes, substantiated by a vast body basic scientific and clinical investigational studies. Algorithm is based upon the reversal of known pathophysiological defects. It has a high probability of achieving durable glycemic control. So ladies and gentlemen, the take-home message from my presentation is, although insulin resistance in liver and muscles are well established early in the natural history of the disease, type 2 diabetes does not occur in the absence of progressive beta cell failure. Impaired insulin secretion, decreased muscle uptake, increased hepatic glucose production, and decreased hepatic glucose uptake all contribute to the glucose intolerance in type 2 diabetic individual. Other factors which contributes to hyperglycemia includes the decrease in incretin effect, alpha cell dysfunction, altered renal glucose handling, and central nervous dysfunction. This paradigm shift, which is based upon the pathophysiology, represents a novel approach to the treatment of type 2 diabetes. It is substantiated by a vast body of basic scientific and clinical investigational studies. Thank you for your patience hearing.
Thank you, Dr. Aravinda, for a very, very excellent lecture. And I think we have seen the paradigm of treatment as per the ADA recommendations, and as you have already enumerated that now this is Sweet 16. So we will be having more branches, like a branch for NASH, a branch for this and that. We will be having more branches in that apart from CKD, heart failure, weight loss, hypoglycemia and other things. So in the years to come, we will have more bifurcations.
Maybe some 24 reasons will come shortly.
So if there are any questions, a couple of questions would be welcome.
Sir, do you think that systemic inflammation should be one of the important pathophysiological mechanism in type 2 diabetes mellitus?
Yeah, so one of the discussion point always is whether diabetes is an inflammatory disease. So if you see, the certain molecules have been implicated for that as well, which is hydroxychloroquine. If you see, that is 200 to 400 milligrams have been used in various aspects, though it is not recommended by any guidelines. But in your systemic, in your clinical practice, when there is an association between diabetes and rheumatoid arthritis or anything where hydroxychloroquine has been used, you can see the better response of diabetes with those patients as well. So that always leads to a discussion whether diabetes is an inflammatory disease. I'm sure that will be one more reason.
Actually, Dr. D. Franjo, who first described this ominous octet, he wrote an article on this regarding the pathophysiological mechanism of type 2 diabetes in Nature Primer many years back, 7-8 years back. And he described decadent decoplete. He added two more components. One of the important components is systemic inflammation, and another is insulin resistance at the level of microcirculation, that is capillary insulin resistance.
So if you,
So
in fact, if you say,
he described this decadent decoplete.
in fact, if you see, the DCHG has
This is the endorsed hydroxychloroquine.
Yeah, approved hydroxychloroquine in the management of type 2 diabetes
yes.
in our country. So we, in our in my clinical practice also, I have used in certain group of patients where there is very good response. And madam was asking about the imiglimine. So that is another molecule which has come into the pipeline where it addresses the mitochondrial dysfunction in diabetes. Once again, the newer technology, newer molecule, newer learning, and efficacy is very good, but where it has to be placed, it all leads to the individual clinical judgment, because the recommendation is not there, long-term studies are not there. But when you are using it, definitely the response is there.
Please. Yeah. Last question.
Sir, one of the main pathophysiological features of type 2 diabetes is insulin resistance, and the main sites of the insulin resistance is muscle. But and if you consider the molecules, mainly it is addressed by the glitazone group of drugs.
Yeah.
But we are, as the time is progressing, we are using lesser and lesser amount of the, glitazone in our private practice. So what is your opinion?
So glitazone is one of the molecules which is been there since many decades, and especially in our clinical practice, I use left and right glitazones. Because whatever the guidelines is there, guidelines is always for your guidelines, that's all. But ultimately it's left to the individual discretion. It leads to an individualized treatment because we know how our patient respond. So in our case, like you take any molecule for that matter, there is a benefit and there is a side effect as well. In that way, pioglitazone also has got benefit and side effects. But especially in our patients where insulin resistance, as you rightly pointed out, is the main reason, pioglitazone will be there, will stay for a long time in our clinical practice, what I personally feel. And Professor D. Franzo, in fact, emphasizes on the use of pioglitazone. Recently, last year also, he was emphasizing about the role of pioglitazone. That is why still it is not gone in the guidelines, it is still there.
So I think we will conclude this session here.
Thank you, sir. Thank you.
Pioglitazone is the most universally used molecule, so there is no doubt about its efficacy on all fronts. And systemic inflammation and insulin resistance is key to not only diabetes but to a longer life. If you want to live longer, you have to address insulin resistance and systemic inflammation. Those are the two key factors to where if you can address that, the lifespan will be extended like anything. Now I will request the illustrious speaker of this session, Dr. Kamlakar Tripathi, Padma Bhushan, and he mixes his talks with beautiful Shero Shari also, and it is a pleasure to listen to him. Thank you.
May not be possible all the time. Thanks. Dr. Jagdishan makes beautiful cinematographic slide. I don't know, I was expecting some of them to be here this time. But one question which was raised before, I think, about the mitochondrial. During the evolution of life, say 5 billion, 4.5 billion years before, there was one cell, and the cell learned from where to get the energy, had a glycolysis because glucose was the base substrate, generated energy, used it. Whatever waste was there, threw it out. When protozoan became metazoan, then this quality of energy conservation came because you had more cell. So you can generate energy, you cannot lose energy. So mitochondria is outside the cell, the bacteria, plant bacteria, migrated into the cell, remembered as a nuclear power project. And the health became very important for the conservation, distribution, and generation of energy. And therefore, the diabetes has now shifted from not only the glycolysis EM pathway, the Krebs cycle. Krebs cycle is now gone back to the mitochondria, not in the main nucleus. So the diabetes has become altogether a real metabolic challenge. We'll go to some of the topic of like why diabetes and renal functions are important, because I said generation of energy was not an issue, but to conserve and then to remove the waste product. So there was pronephros to begin with. This is the first week of life you have from the germ. The ectoderm, part of the ectoderm migrated into the form of allantois. And from the allantois, you generated three systems. The pronephros, which is just filtering, throwing out. The mesonephros, close to 5 weeks. And then metanephric cap, which came from the mesodermal origin. So you have two origins in the kidney. The ectodermal, invaginated, the mesoderm. So the capillary, the blood vessel, the filtering system comes from there. That regulates the pressure because you had a pump, and the classical presentation, pump, tube, filter. And therefore, the role interplay between the two came into the existence. This is the vesicle you have, and then ultimately this vesicle took a shape, formed the tubular system, and then formed the filtration. The pancreas also developed from the bud, the same ectodermal blood, from the gut primordia. Two different bud, one ventral, one dorsal, came together. One became the head of the pancreas, remaining became the tail of the pancreas. Therefore, embryologically, they have all signal, they remember in their brain what is to be done. And so the two main receptors, SGLT1, SGLT2, 10% gut, 90% tubule, altered SGLT1, 90% in the tubule, 10% in the gut. And this is important to understand why tubular maxima concept was created, to throw the waste out. So kidney took the job of regulating the extracellular fluid, the volume, the pressure, so that it can filter, and it can give a feedback to the heart and the vascular system. And you don't do that, then heart fails, kidney also fails. But kidney, like liver, has 2-3 more jobs to do. Gluconeogenesis, and also to some extent by stopping the absorption of the glucose, getting it back to the system. And I was talking to this slide. You have a mitochondria here, the TCA cycle, the Krebs cycle from the main EM pathway. Kidney also does the same thing. It also takes advantage of pyruvate cycling, and then it does the generation of the glucose. So it makes a balance between the two. And as long as the tubular maximum is retained, kidney tries to conserve it, otherwise it doesn't. This is the gluconeogenesis in the cortical part, and this is into the renal medulla. Renal medulla utilizes glucose, cortex regenerate glucose, and that's the extra advantage other than the liver. Second part is maintaining the filtration gradient to perfuse. And you have this important slide. This is the intraglomerular pressure, only 55 millimeter mercury. Afferent arterial pressure comes somewhere close to 30 millimeter. Hydrostatic pressure done by both, the water pressure, both sides, 15. So net filtration gradient is only 10 millimeter mercury. What would happen when your blood pressure is dropped in this hot summer season? You get patient systolic 50. So you should not make single drop of urine. But it doesn't happen because afferent arteriole, the macula densa, they try to regulate. So the factors which regulate is the vascular factor like nitric oxide, COX-2, calcarine, kinin, ANF, angiotensin, tubular signals, and then also fraction causing the net increase of different arterial resistance, angiotensin 2, thromboxane A, endothelin. All these molecules have been used in treatment of diabetic nephropathy, and that's the importance of knowing these molecules. Therefore, inflammation, obesity, you were talking of the anti-inflammatory substance. All these pro-inflammatory cytokine, IL-6, IL-12, IL-8, have been studied to create insulin resistance. And therefore, the chronic, persistent, low-grade inflammation is one of the causes of insulin resistance in some of the very poor people, marasmic people, do not have any food to eat. So the mother develops, but as well as the rest of the members also develop insulin resistance over the time. And therefore, these are, I was talking mitochondria, the site, all inflammatory cytokine. Look at the list 1, 6, 18. Metabolic, look at the ROS, TGF-alpha, PK, protein kinase C, hemodynamic factor, fibrotic factor. All they contribute in the pathogenesis of diabetic kidney disease. It is the nephron endowment. The Brenner came in India. He continued to come for 8 to 10 years, but celebrity, more than a Nobel Prize winner in renal medicine, Barry M. Brenner, and he gave the concept how many number of nephron you are born with. If you have a less number of nephron, the taxation is more work, more filtration, and this is the only organ in the body after the liver which has a potential to regenerate about 100% to 200 to 300%. You take one kidney out, do nephrectomy, pyonephrosis, the other kidney takes 100% job, creatinine remains all the time normal. So it depends on aging, diabetes, hypertension, as well as the glomerular injury, and the hyperfiltration, which is one reason because of the blood pressure, lead to hypertrophy. This hyperfiltration theory, and why you use medicine, you use SGLT2 inhibitor, you use angiotensin 2 converting enzyme inhibitor, they use calcium channel blocker, cilindipine, they correct the intraglomerular hypertension. This depends on the weight, depends on the growth, depends on the various cytokines and obesity. There's a word called absolute hyperfiltration, which is based on the single nephron GFR. Like Brenner, we had another celebrity in renal medicine, Bricker's intact nephron hypothesis. He says you ablate the nephron, remaining nephron will take the job of 100%. You further ablate, they would take up the 200%, and each nephron would try to compensate as long as he is surviving. So relative hyperfiltration is an increase in SNGFR in the setting of reduced number of functioning nephron. If you are born with less nephron, remaining nephron would have a taxation. Independent or absolute hyperfiltration, persistent increase in GFR associated with glomerular hypertension can eventually lead to proteinuria, glomerulosclerosis, and decline of kidney function. So in diabetes, we have two arms. One is the hyperglycemia persistently right from the beginning. You have blood pressure leading to the glomerular hypertension. And these are the two different drugs which have been now being used, proteinuria, and there's interstitial fibrosis and lead to renal failure. We have two sorts of nephron, medullary nephron, cortical nephron. They have a long loop of the Henle. So if there's more water, they try to conserve. Short water, excessive water drinking, they try to short back, and with the vasa recti. This is the normal phase of filtration. This is the renal functional rhythm. And that's why initial work with captopril, long back, all these ACE converting enzyme inhibitors, the concept was conceived. In diabetes, you have a more vascular neogenesis, more wider bed, so you filtrate more. That's called stage 1, hyperfiltration. And if you want to use ACE inhibitor as a prevention, you use right over there so that you decrease the proteinuria. You try to bring the hyperfiltration to normal filtration. But in phase 2, the normal filtration still continues. Albumin excretion slowly takes up, and it becomes half as there's hypofiltration, and ultimately there's GFR decline. So we have lot of renal functional reserve. That's why serum creatinine would not rise unless 50% kidney function has been lost. And therefore we work now eGFR. Even in eGFR also, as long as you have a 45-50, creatinine would remain stable. The moment you start falling more than that, the sharp rise of the serum creatinine 1.8, 2.4. This is the reason why using SGLT2 inhibitor, even for that purpose, ACE inhibitor or ARBs, if you remain silent, you don't watch your patient, which time an elderly patient would develop his renal failure, you will miss a story. So need to look at the values very closely and critically. What are the risk factors? Decreased number of nephron, metabolic obesity, hypertrophy, and all these lead to hyperglycemic mediated cell injury, endothelial cell, mesangial cell, matrix, podocyte. I'll come in a moment quickly on this podocyte business. So we started a story from the metabolic, from the filtration. Now we are coming to the molecular level at the podocyte, the barrier, the basement membrane. It has a two junction, one epithelial cell coming from the allantois, the gut primordia, second is coming from the mesodermal layer, the capillary, the endothelium, two mixed together form a basement membrane. Now this basement membrane could be damaged because of the continuous hyperglycemia, hexosamine pathway, PKC, and because of the cell abnormality, this change into the structural as well as functional component, which would lead to increased permeation of the protein. Dada wrote a book on diabetic kidney disease and gave it to me at the airport, Kolkata, last time. This is the diagram, this basement membrane, the capillary. In the mesenchyme, it loses basement. This is the only place in anatomy where you do not have a basement membrane. You have floating cell only, bathing continuously the mesenchyme, the matrix. And in the matrix, you have all the very important cells which are called anti-idiotypic antibody cell. They try to protect your kidney. And excess production of mesangial matrix is one of the earliest signs of diabetic kidney disease. So this high glucose with collagen proliferation and mesangial expansion takes to increase in mesangial volume, change in matrix composition, change in structure, and changes stiffness. This is the urinary space. These are the podocyte, and these are the food processes. They efface. When they efface, they lose the power. Protein is a negative charge. Albumin is a negative charge. Basement membrane is a shallow protein, negative charge. They repel. But the moment inflammatory changes occur, they retract. And when they retract together, then they leak into the urine. This is called podocytopathy, another branch of science. There's injury, and there are hemodynamic changes. There are the systemic intraglomerular hypertension, and this is manifested as cell hypertrophy, food processes widening, in leading to podocytopenia. This is good word which is coming now in molecular medicine, epithelial mesenchymal transition. So when the local army fails, there's a riot in the Bengal, there's political problem, then you recruit, you ask the central forces to come. So the memory which was there for the single cell amoeba log 4.5 billion years before, it was part of the allantois with the ectoderm, remains the memory. And when the barrier has lost, then these cells, they migrate and they take the role of the mesenchyme. So ectodermal mesenchyme transition, and this is important in understanding the molecular signal. Now this cell would produce more fibroblast, would lead to ultimately glomerular sclerosis. So you started from the membranopathy, podocyte injury, mesenchymal migration, inflammatory changes, coming to the fibroblast cell, ultimately glomerular sclerosis, total obsolescence of the glomerulus. So you have many pathological processes going on together. You have an endothelial dysfunction for the vascular bed. You have a tubular injury because of the filtration process. Then you have an interstitial inflammation, lot of inflammatory cell migrating into, and ultimately lead to fibrosis. So you lost the kidney. And if you look at sometimes autopsy of those patients who have died after the renal transplant, it is like a small almond L shape. Everything looks so fibrous, absolutely distortion of complete anatomy. Then you have a lot of growth factor. And we are going to have the molecule of these growth factor. And we have the drugs accordingly. And they are responsible for the proliferation of the endothelial bed. And we try to block them. Endothelin T1. And there is a drug also, Avacenton, which is in the market. I'm not going to talk that drug right now. Then there you have a podocyte-based some of the biomarkers, nephrin, GO, SNS, detachment, and all we have a drugs now against this molecule. So in normal physiology, you have these factors which are upregulated, endothelial distress factor, angiopoietin, nitric oxide, and in diabetic glomerulopathy, they all get from upregulated, and some of them get downregulated. This is, I just quoted it, long back, 1993, I published an article in Nephron 2 Minutes, in which pentoxifylline was used. Now, even today, this has got a relevance, and still we keep on. And these are the molecule different way, looking at the RBC rheology, looking at the fibrin, looking at the filtration. Quickly, I'll go some of the biomarkers, but what is important that you have biomarker at the site of the glomerulus, you have biomarker at the tubule, you have biomarker at the bladder level, interstitial. So, and this is the last few slides, depending on the what topic was given to me, between the correlation, the cardiac factor, the renal factor. You have 5-way. This is called cardiorenal syndrome. The first, heart phase, kidney filtration affected. Second, kidney phase, heart fluid overload is there. Third, both fail together. There's increased interstitial fibrosis. And the fifth, the combination of the two. These are the 4 pillars you all know now. So you have the old school like me, outdated man. Dada is still young. So you could use these guidelines for metformin lifestyle. You have ACE-ARB, maximum dose. Then you have SGLT2. And then you have a Finerenone, the last popular drugs. And these are some of the studies, the outcome history, fidelity. You can use now all the 3. You can use MRA, you can ACE inhibitor, you can use SGLT2 inhibitor, and you can also use all the 4 together. These are the recent trial, Fidelio, DKD, Figario, DKD, and Fidelity, in which all the 3 drugs have been used. But this is what I brought. This is the 2024 publication. Look at the value. Do not close your eye and use a molecule because it is written in the drug or given by the pharma house. This is the area where you still have to abide, where eGFR is low, less than 29 or 15, and the proteinuria on this. These are the green zones. Safely you can prescribe any medicine, all 4 combination. But this is the red zone. Please do not use. We nephrologists continue to see such patients where others have given all these 4 drugs, patients have deteriorated. So you are accountable. Patient will ask you, sir, why did you use this molecule? And you have to be answerable for it. So thank you very much for listening, and try to complete within short time.
Thank you, sir, for a very excellent talk. There is a question from my side. So what is the advantage of Finerenone over aldosterone and the older MRAs?
Finerenone, all these MRAs, primarily they are responsible for 2 things: to prevent the fibrosis on cardiac size, because at molecular level they affect the connexin fiber, and at the tubular level they take care of the proteinuria. Because diabetic nephropathy to fibrosis occur takes 15 to 20 years. Proteinuria is the first initial part. So if you use Finerenone, then you answer your proteinuria short term. In the long term, you prevent the fibrosis. That's the quick and short answer.
Any questions from the audience?
Thank you.
Thank you, sir.
Now is the turn.
One question before I go.
Yeah, please go ahead.
The recipient, donor of a kidney donors, does the same thing happen?
Kidney donor,
Single-
we initially try to work on the excretory part first. At least patient should have a EGFR acceptable range. But we also look at the biomarkers now, which we are not people were looking initially. If you have an option with a live donor, deceased donor you cannot, but with the live donor you have an option, it is better to now look at some of the biomarkers like nephrin, and if it is there, the quality of life would be poor. So now good centers, they do it. It's costly.
Now I would invite the next chairperson, a good friend of mine, a charmer, and
Speaker.
more than that, a great speaker and a great academician. She has done a lot of work in type 1 diabetes. So please, over to you, Dr. Beena, to give your insights in recent development in type 1 diabetes research.
So, good afternoon, everybody. So, I hope you are interested because most of us are interested in type 2. And one doctor in Delhi particularly sends the patients to me and saying that I have a lot of time to waste. So, because type 1s need more time than type 2s, you can't write a prescription in 5 minutes and throw them out. So what I'll be talking about in recent advancements is recent advancement in prevention, evolution in insulin delivery systems, advances in glucose monitoring, and advancements in insulin therapy. So we'll just start from the basics, the stages of type 1 diabetes. These were found out because 200,000 first degree relatives, which means siblings, parents, and children of type 1 diabetics were studied for a very, very long time. And among these 200,000 type 1s who were studied, the first degree relatives, it was found that stage 1 is when there are 2 or more autoantibodies, but there's normoglycemia. Stage 2 of type 1 diabetes, when there may be 2 or even more than 2 autoantibodies, and now the patient has dysglycemia, which is actually impaired glucose tolerance in type 2. So the fasting is 110 to 126, and the postprandials are between 140 to 200. Now stage 3, which is frank type 1 diabetes, is more than 2 autoantibodies, and now the patient is hyperglycemic, has symptoms of diabetes, and exogenous insulin is required. So the percentage of diabetes-free person, so this is what I'm going to talk about today in my first part of my presentation, that now there is a drug, we've been talking about monoclonal antibodies, there is a drug which can prevent stage 2 from becoming stage 3. So why so much hue and cry? Just because stage 2 didn't become stage 3, doctors, you can imagine if a 2-year-old sibling of a type 1 diabetic who is 8 years old and the mother is struggling to look after that type 1 has a sibling who has 2 or more positive antibodies and dysglycemia and can afford to be on this drug, teplizumab, you could delay onset of type 1 by 2 years and even more in some patients. So just before we know, you should know the basics. So the T cell receptor does not signal on its own. You can see the T cell receptor there, but rather through association with CD3 co-receptors. The T cell is a lymphocyte. So in the autoimmune process, CD3 is the intracellular signaling component of the T cell receptor component. You can see there, that's the T cell receptor complex, and it has the CD3 has to be attached to it. Now what does the teplizumab do? It binds to the CD3, causing internalization of the receptor complex and changes in gene expression. So now this T cell receptor complex cannot damage the beta cells for some time. Now this is interesting. Stage 1, where the T cells begin to attack insulin producing beta cells in the pancreas. Stage 2, some beta cells are destroyed, leading to dysglycemia. Now we could delay stage 2 to stage 3 by giving teplizumab, because it will now bind to the CD3 on the T cells, slowing their attack on the beta cells. So it's as simple. You can prevent stage 2 from going into stage 3 by giving teplizumab. Now it's a very, very expensive drug, and I'll just talk quickly about the studies. And in spite of giving teplizumab, you cannot prevent type 1 diabetes. It does happen, but it's an immunomodulator, and you can delay type 1 diabetes. Now, what was the eligibility for treatment? You should have a confirmed documented diagnosis of stage 2. That means you definitely have 2 or more autoantibodies which are positive. Dysglycemia without overt hyperglycemia, because if you have overt hyperglycemia, you are obviously already type 1 stage 3. This could be based on an oral glucose tolerance test, and if an OGTT is not available, probably you could take a fasting plasma glucose between 110 to 126 or an HbA1c value. Now, no clinical history suggestive of type 2, which means no family history of type 2, no acanthosis, no other stigma of metabolic syndrome. So, these patients were then relative of a patient with type. When I say relative, it's a first degree relative and not a cousin, but it's a first degree relative, which means either a sibling, parent, or child. Age more than 8 years. At least 2 type 1 diabetes related autoantibodies, evidence of dysglycemia, fasting between 110 to 125, and 2 hour postprandial 140 to 199. In the study, they also included a 30-minute, a 60-minute, or a 90-minute postprandial glucose, more than 200 on 2 occasions. These patients were randomized to receive teplizumab or placebo, and they were followed up at 3 months, 6 months, and then every 6 months. And the primary outcome measure was whether they went into stage 3 of type 1 diabetes or not. That means whether they developed overt hyperglycemia. So primary analysis with 2 years of follow-up showed that teplizumab group, it took 48.4 months to go from stage 2 to stage 3, while in the placebo, it took 24 months. So a good 2 years, stage 2 to stage 3 was postponed, and which is 2 years, a very long period for, say, a 4-year-old, so he will become type 1 at 6. Then there's another trial. So this was the trial NET. This is another trial that happened, which is known as the PROTEGE trial. And it was found in this trial, again, patients were randomized to receive different doses of teplizumab. So a 14 full-day course, full dose, a 14-day low dose, a 6-day full dose, and then placebo. So 4 groups, 1:1:1. In fact, 2:1:1. And then again, it was found that the loss of the reduction in C-peptide was lowest in the group that received a 14-day full dose of teplizumab. So there are other disease-modifying therapies. Cell therapy is available. So you know we have islet transplantation, which can provide insulin independence. Stem cell-based implantation, Dr. Bhansali tried this, but the patient remained insulin-free for a very short time. You could use mesenchymal stem cells. Also, there is need for immunosuppression. So instead of immunosuppression, why not give insulin to the patient? So this has not been very successful. Now, cell replacement has been effective. Islet cells, but where you get the donor islet? Usually from aborted fetuses, but it's difficult. And it requires broad immunosuppression, so it defeats the purpose. Naked cell therapy. Now, insulin-producing cell sources under developing. I just mentioned they can be derived from stem cells from other animal sources, like xenoporcine islet. Then how do you protect the cells after transplantation? This is important because once you transplant islet cell, you can protect it by encapsulation, gene editing, scaffolding, or by immune modulation. Now, I think I'll come to my favorite topic, which is evolution in insulin delivery systems. So, continuous subcutaneous insulin infusion. I have a lot of patients on the insulin pumps. Insulin pump technology has advanced rapidly. It helps the patients achieve tight glycemic control. I'll just skip quickly through these slides. We have the Minimed 630, we have the 770, we have the SmartGuard technology. Now this is the state-of-the-art pump, the Minimed 780G, it's very costly. What is the advantage of a pump which is SmartGuard technology? Because the advantage is that several advantages, but one that comes to my mind is that it chooses the basal dose. So every minute it can change the basal rate so that the patients have very flat sugar profile. The key features, new meal detection technology that auto-adjusts the basal and bolus insulin. Targets can be set as low as 100. Infusion site can be worn up to 7 days. Reservoir that can be swapped independently of infusion set. This is not available in India. This means that normally you can only fill in a particular amount of insulin. So if you don't want to change the infusion set, you can change the reservoir, so cost goes down because you can do it. And the biggest advantage, low glucose suspend happens when the sugar is less than 70. So there's a hypoglycemia alarm. Now we come to continuous glucose monitoring. There's a very important question we ask our DNB students. If you are a patient type 1 is asked to choose between a pump and glucose monitoring, what will you choose? So anybody from the audience, if you had the option of choosing a pump or glucose monitoring, what would you choose for the patient? I think, monitoring, yes. So monitoring has dramatically changed the outcome of type 1 diabetes. Whether you give basal and boluses, but monitoring is more important than, so even before pumps, if the patient is non-affordable, I think CGMS has changed their lives dramatically, because we would get a lot of nocturnal hypoglycemia which was missed, and then you had a patient with hyperglycemia in the morning. Now you would wonder whether this hyperglycemia is post-hypoglycemic hyperglycemia due to some Mogai phenomena, or is it because of dawn phenomena and early morning rise in blood sugar. So we were struggling in a type 1s with nocturnal hypoglycemia. Even with the best basal insulins like Degludec and U300 glargine, we do find episodes of hypoglycemia, particularly nocturnal. And now with the continuous glucose monitoring, you can easily pick up hypoglycemia. Doctors, you'll be surprised that our patients can actually tell you. So I had a patient who had hyperglycemia before lunch. And I would always ask him, you get hypoglycemia, I'm sure you eat something in school between breakfast and lunch, a tiffin or a snack. He's the one who got a sensor, a flash glucose monitor, and he pointed out that at 12 o'clock post-breakfast, after his morning dose of regular insulin, he dips. And when he has a feeling of a drop of insulin, he snacks. So that is why at 1:45 or 2 just before lunch, he has a very high sugar. So we picked up in the continuous glucose monitoring this low sugar, and he just had half an apple just before the hypoglycemia, so that he didn't have to correct the hypoglycemia with simple sugars, so that post-hypoglycemic hyperglycemia disappeared. So with the simple continuous glucose monitoring device, you can pick up hypoglycemias and you can be proactive. Another thing that is so continuous glucose monitoring is different from intermittent glucose. So any continuous glucose monitoring, you don't need to scan. But all of us are now using flash glucose monitors also. So just to bring out the difference, in flash glucose monitoring, you have the Libre sensor and the Libre Pro. Now we are using Libre sensors. You'll have to, so sensor it will sense the interstitial glucose, and it will transmit it. It has a transmitter. It can transmit it to the reader, it can transmit it to the pump, and it can transmit it to the app in your phone. So anyways, it will transmit. So the patients can download the app, and when they bring their phone next to their sensor, it tells you the sugar. So, or they can have a reader which they can buy, and it will tell you the sugar. It also tells you, it has a arrow. So if the arrow is straight up, that means sugars are going to rise quickly. If the arrow goes down, they're going to fall sharply. If the arrow is a little, not exactly vertical, but a little, like this, tilted, it means the sugar is going to fall, but slowly. And similarly, if it's going up, it can rise, but slowly. And if it is flat horizontal, it means sugar is going to remain the same. So monitoring of sugars, what you can see, you can react. So I think this, in my mind, is the biggest innovation that has happened in the field of type 1 diabetes. Now, I was talking about flash glucose monitors. We are doing it regularly. We've changed the lives of our type 1 diabetic patient with flash glucose monitoring. We are using both Libre sensors and Libre Pro sensors. We've seen that CGM is superior, so we do have CGM. The Medtronic pump has CGM. Also, we have Guardian Connect, which is a better, I don't know if it's available in Kolkata, but in Delhi we do have Guardian Connect. So we've seen that between CGM, continuous glucose monitoring, where you don't need to scan, and flash glucose monitoring, CGM slightly better HbA1c data. So I'll skip this. Real world evidence of CGM in type 1 diabetes. There have been several studies. Now I'll come to, so this is the real-time CGM. Then you have the intermittent CGM where you can scan and you get values. You can scan as many number of times as you want. Now I'll talk about the last part, innovation in the form of insulins. So now we have ultra fast acting insulins. We also have ultra long acting insulins. So we all know there is ultra fast acting Fiasp. So you can see the difference. So the area under the curve with regular insulin, then so with every insulin, doctors, we must know onset of action, peak action, and duration of action. So with a fast acting insulin, the advantage is it peaks higher, so it addresses the postprandial blood sugar. Its onset is quicker. So the onset depends on how quickly the insulin changes from hexameric to dimeric to monomeric form in the subcutaneous space, because all insulins, whether in vials or cartridges, are in the hexameric form. So we had Lispro, then we had, now we also have ultra fast acting Lispro. Lumjev has been launched. So it quickly changes from hexameric to dimeric to monomeric, and the onset of action is even quicker. It's very effective in little children where you can inject even after the meal. And similarly, NovoRapid has faster aspart, which is known as Fiasp. So again, by changing the amino acid sequence, we can make the insulin rapid acting and even ultra rapid acting, ultra short acting. But there are certain conditions where you need a larger area under the curve. And that is when you use regular insulin. For example, when the gap between the meals, for example, the child is going to school, so you need, he's not going to eat for 5 to 6 hours, then maybe you can use a regular insulin. So and then you have improved new generation basal insulins. So similar to the regular insulin, where onset of action, rapidity with which it acts, peak action, and duration is important, for basal insulins, what is important is it should be peakless. So we had NPH insulins which had to be given twice. There was a lot of inter-individual and intra-individual variation. In the same patient, same dose will sometimes cause hypoglycemia, NPH. So we had to give it twice. Now then we had the state-of-the-art Glargine, did not act for 24 hours, particularly smaller doses. In my patients on CGM, I have seen that in 22 to 23 hours, the action almost wanes off with Glargine. So you have U300 Glargine. Yeah, so that's why I'm just coming to the end. U300 Glargine acts longer, and we have Degludec, which acts even longer. So this is the faster aspart. So I've talked about it. And this is the insulin Degludec, which is ultra long acting, because you can see it stacks up as hexamers, and then you can see that it acts. So then you have a window of opportunity. You can give it later in the day if the patient is, say, going to school or going for tuition and cannot take it at the same time day after day. So there is lesser variability. So I like to conclude by saying that there are a lot of innovations in the type 1 diabetes space, but one innovation that stands out is the use of monitoring devices. So doctors, my plea to all of you is to try using it, and you'll be so happy even in type 2s. We've actually seen people have hypoglycemia in the middle of the night with glimepiride and with gliclazide, and it's much better when you stop the glimepiride and gliclazide and you put the patients on drugs which do not cause hypoglycemia, like SGLT2 inhibitors or metformin or glitazones. So similarly in the type 1 space, I think one innovation I love is the availability of sensors, flash glucose monitoring. You could teach your patient, they all have Android phones and children learn very quickly. And regarding teplizumab, we have a long way to go. We need immunomodulators, but whether they can be appropriate for a country like India, where even in a place like Delhi, most labs are not doing all the autoantibodies. So if I write zinc transporter 8, insulin IA2, insulinoma associated antibody 2, islet cell antibodies and GAD, patient will come back and say only GAD is available, they don't know what are the others. So in a place like Delhi, if we don't have all the autoantibodies, how do you expect us to detect 2 or more antibodies and then put the patient on immunomodulation? So as a rule, I don't test antibodies in my patients' siblings. I'll just tell them that there is a possibility and you should be aware. Why I don't tell them is to do the autoantibodies is obvious, they'll be sad, we can't do much. And so we don't do the autoantibodies in the first degree relatives, but I have a series of patients where both brothers, one brother, sister, and very interesting, that's last 1 minute. I had a daughter who was,
There is a lunch break, no issue.
okay, so there was a girl who was type 1 diabetic following up with me for 12 years, and her father was type 2. Her mother came to me with diabetes and I said, well, it's type 2 and put her on usual gliclazide, metformin and some DPP-4, but she was not controlled at all. And when we did her C-peptide, it was normal. So I thought she was again type 2 and continued to give sulfonylurea by increasing the dose, but lo and behold, her sugars remain. So in the range of 300, and then we put her on insulin, and when we did the autoantibodies, GAD was positive strongly, zinc transporter 8 was strongly positive. So this is a very interesting case where the child developed type 1 diabetes at the age of 3 or 4, and the mother developed type 1 at the age of 45. So we have to keep our eyes and ears open. We used to say type 1 is not hereditary. In lots of cases it is. There is a genetic predisposition, and that is for another day, the HLA and all that. But yes, so I think my message is that type 1 space, we need to do more and more self-monitoring of blood glucose, and we need to put sensors. Thank you.
Thank you, Dr. Meena, for such a wonderful insight in glucose monitoring systems in type 1 diabetic and newer advances in insulin delivery systems. So, any questions from the audience for Dr. Meena? No questions?
Regarding the use of teplizumab, is it increasing any risk of infection in these patients?
What did you say? Pumps?
Teplizumab. Huh?
Teplizumab.
Oh, no, it did not. It did not. So we had to see, because we know that they can even increase risk of tuberculosis
and infection.
But you know what? The follow-ups are going on. I have not followed up the trial net regarding
Basically,
infection.
we are living in a country where, particularly during the COVID situation, we are getting more number of tuberculosis those who have given tocilizumab.
Yeah.
So that's why
Yes.
I'm asking.
Yeah, because that was the problem when we were treating COVID with the MABs, monoclonal antibodies. We could get later tuberculosis. But in the TrialNet study, the study is still following up the patients who were on teplizumab. I have not read, doctor, whether there was increased incidence of infection. And a big thank you to Dr. Patni for inviting me here. A lot of doctors don't get a place in the conferences because they speak about type 1. Because it's a space which is occupied by very few people. Thank you, Dr. Patni.
Thank you once again, Dr. Meena. So, do we close the session? Okay. Thank you, all the speakers.
Thank you. I request the chairpersons and speakers to go to photo booth and take the photos for the memento. And now we break for the lunch. Faculty lunch is arranged in the faculty hall and delegate lunch in the lunch area. And now we meet again at 1:50 for the post-lunch session. We'll be assembled here by 1:50. So to moderate the session, I invite Dr. Sushil Patel to come to the dais and continue the proceedings.
Good afternoon, all of you. I'm Dr. Sushil Patel. In the absence of Dr. Dharmendra Pranchal, I am going to moderate the session. So session is about the diabetic emergency preparedness workshop. So why we need to be prepared for the diabetic emergencies and at what level? It can be at the home level for the patients. So patient should be prepared, and or the patient's family member, more importantly, should be prepared for the diabetic emergencies, because in the emergencies, patient may not able to act upon the emergency condition, but the family member should be educated like that they can take a rapid response for the patient's condition. And the second thing is how the hospitals can be prepared for the diabetic emergencies. So, for this session, we have Dr. Malay Parekh with us and the Dr. Jayan Sharma. If he is around, then he can join us, otherwise whenever he is coming. So, what is the common emergencies we are dealing with in our day-to-day practice? It can be the acute hyperglycemia that is leading to the decay, or the HHS, that is osmolar hyperglycemic signs, and the hypoglycemia, and the other may be the cardiovascular complications or the cardiovascular emergencies. So preparing for the emergencies, it can be individual level, what I had told you, the patient level or the family members level or the physician or the institute level, and it can be some point at where the public or general public can be educated at the society level, because many of times what happens that the patient is doing exercise in the park or on the road and they fall because of the hypoglycemia, and the people are not educated about the hypoglycemia, what should be done. So we will going to discuss all this one by one. So for about the decay and the HSS, we have Dr. Malay Parekh with us. So this is a common scenario. 14-year-old boy was brought to the hospital with the complaints of abdominal pain, breathing difficulty, and the vomiting. On examination, patient is drowsy, acidotic breathing, blood pressure is 88/58, pulse is 114, respiratory rate is 26, capillary blood sugar measure is 522. Patient is not known to have diabetic. So first thing is that what should be done, and what is the decay?
Yes.
Can you elaborate from that basic point?
Yes, thank you, Dr. Sushil, for wonderful moderation. And this is the very unique and regular case which we encounter in day-to-day our routine clinical practice and in our OPD. Suppose the 14-year boy came into our OPD with these symptoms, and we found this is a decay. But what is decay? It is a totally metabolically abnormality, and due to exclusive absolute insulin deficiency, and which encountered the main three symptoms. First is the hyperglycemia, second is the acidosis, and third is the metabolic derangement, right? Means hyperglycemia, metabolic acidosis, and there is a electrolyte disturbance. So this is the diabetic ketoacidosis, and there is a significant ketonuria and ketonemia in the body. So this type of presentation, which means there you have to first in the mind, it is a case of the diabetic ketoacidosis. Yes.
So how we can diagnose this diabetic ketoacidosis?
Yeah. So these are various signs and the symptoms. So which are the symptoms, right? So first is the polyuria and the polydipsia, means there is an increased thirst and increased urination. And another is there is a significant weight loss. And there is a typical symptom of the decay is the abdominal pain, nausea, and the vomiting. So these are the symptoms came into our emergency and you are our OPD. Suppose the 14-year-old boy, he has the severe abdominal pain, nausea, vomiting, blood pressure is very low, and he has some abnormal breathing. So these are the, and polyuria, polydipsia, weight loss. So these are the some symptoms. And what you can find as a sign of the decay means there is a Kussmaul's breathing, there is a hyperventilation, there is a hypovolemia, there is a hyperglycemia, even there is a hypokalemia is there, and there is a lot of loss of skin turgor. So and there is a patient is totally drowsy, stupor, or even in the sometimes in the coma. So these are the signs of the diabetic ketoacidosis.
So like what we had seen in this case, this is a patient is not known to have the diabetes. So ideally this may be the newly detected type 1 diabetic patient.
Yes.
Right? So this is the patient where patient doesn't know anything about the diabetes.
Right.
They are coming to know for the first time because of the symptoms of the decay, and a majority of decay patients are type 1 diabetes patients are diagnosed with the decay.
Yes.
Right? But another thing is that patient already having the type 1 diabetes.
Yeah.
They are already on the insulin.
Yes.
And now they are developing the decay, right?
Yes.
So what can be the precipitating factors for the development of decay in the type 1 diabetic patient?
Yes, very important question, because as we know, sir mentioned, almost all type 1 patients sometimes develop the decay. And the precipitating factor, the most common is the infection. Is there any infection which led to the decay, right? Another is there is a myocardial infarction also. Sometimes there is a cerebrovascular accident also. Even the most common is the drug, sometimes drug also. Even alcohol and acute pancreatitis, it's also a precipitating cause of the decay.
So for the type 1 diabetes, it is very much important what we have to educate the patient. If they have any kind of infection, then they should suspect that they are at the risk of development of the decay. So another question from here is that what can be the steps what a patient should take at the home? Right. Because we are talking about the emergency preparedness. So what steps that patient can take at the home, or the patient's relative can take at the home?
Yes.
If they suspect the decay, or how to suspect the decay at home by the relatives?
So what are the features of the decay? Once you check the sugar and the sugar is almost more than 250s, sometimes your breathing is abnormal. Sometimes there is a breath odor is the light acidic or ketosis odor breath. So these are the some logical cues of the diabetic ketoacidosis. And sometimes some patients has the fever or any infection. So take the proper hydration, because there is some hypovolemia in the decay. So give the maximum fluid supplements to the patients, proper treatment of the any viral infection. And the most important is to take the urine ketone strips at home. Just in that time, just check your urine sample with this strip, and if there is any positive in the strip, so you can easily access and easily you can check it is a case of the diabetic ketoacidosis. And there are the 3 types of the decay: mild, moderate, and severe. So what are the main investigation you can do, right?
Yeah. So for the home, that patients or the patient's family members should be educated, and they should be advised, each and every type 1 diabetic patient should be advised to at least have the urine ketone strip at the home, right? So that if the patient is having the ketone strips and the patient is having the infection, at the same time, if the patient is measuring the sugar level, and if it is on the higher side, then they should check the ketone level at least daily basis. And if that found positive, and if the patient has the symptoms which is suggesting of the decay, then they should immediately go to the doctor or the nearby hospital for the emergency management, right? So this is what about the home management. Another thing which comes in my mind from this thing, that many type 2 diabetic patients are also having the decay.
Yes.
Even maybe type 2 diabetic patient diagnosed with the decay.
Right.
So what is your comment on that?
Yes. What you suggest, only type 1 patient develop the decay? Is there any? Yes, sir. You are very right. Even sometimes type 2 patient also, and even sometimes who are on the pump insulin therapy, sometimes type 2 also on the pump therapy, and sometimes there is a mechanical failure of the pump, and they develop also the diabetic ketoacidosis. So as sir mentioned, what about the hospital treatment? So early as you just go to the emergency department and start the IV fluid therapy, because there is the first and almost the main treatment is the IV fluid. So as I mentioned, there is a 3 types: mild, moderate, and severe. So how you assess there is a mild decay, moderate decay, or severe decay? And by that you have to send the ABG analysis. And if the pH is less than 7, so it is a severe decay. If the pH is between 7 to 7.25, it is a moderate. And there is a 7.25 to 7.35, it's a mild decay. So these are the some. And the first treatment is the IV fluid therapy. Just start the 1 liter in the first, and give the IV route is the best. If there is no assessment from the IV, then you can do the IM. But IV is the best and the treatment of choice. Then 1 liter you can do the next 2 hours, and another 1 liter is 4 to 6 hours, and another 1 liter is the after 8 hours. So almost 4 to 6 normal saline you can give in the first 24 hours. If the sugar is now come to the less than 250, then you change the from normal saline to D5, means dextrose normal saline, because there is some chance of the hypoglycemia. So you can change after the 250 once the sugar reach. And you can check all the blood report necessary. First and most important is the electrolytes like sodium, potassium and the chloride. With that you can check the liver function, kidney function, even ABG. And if possible, there is a ECG is the most important parameter to check the diabetic acidosis. And after that, you can give the potassium supplements, but if potassium less than 3.3, then don't give the potassium because insulin also can lead to the hypokalemia. So if potassium less than 3.3, don't give, and if potassium more than 5.5, then wait, don't give. And after that, you can BiTAB is less than some normal value, you can give the BiTAB. But after fluid, the most important is the insulin treatment. And for that, normal regular insulin is the ideal treatment of choice for the diabetic ketoacidosis.
So here what the point I want to make here is that majority of time what happens that immediately we see the sugar level is more than 400 or 500, and at majority of centers we all know that the decay is basically developed because of the deficiency of insulin. So we immediately start the therapy with the insulin, and this is the fault what many centers are doing. The first thing is to correct the fluid imbalance.
Yes.
First thing is to correct the electrolyte imbalance. It is a major part of the decay management. Simultaneously, what you can do the insulin therapy with either the infusion pump, which is ideal. If the infusion pump is not available, then you can put this insulin in the drip, and then you can titrate the dose of insulin according to the blood sugar level, right? So this is what about the treatment or the emergency preparedness at the hospital. But then if